diseases of the bowel, inflammatory bowel disease, and irritable bowel syndrome. Clinical presentations. Clinical presentations. These diseases are ulcerative colitis, UC, and Crohn's disease, CD. UC is a chronic inflammatory condition of the gastrointestinal tract mucosa and is primarily found in the rectum and colon. CD is chronic transmural inflammation of the gastrointestinal mucosa and can be found throughout the gastrointestinal tract from the mouth to the anus. CD most commonly affects the small bowel and colon. 2. Irritable bowel syndrome, IBS, is a disorder that interferes with the normal motility functions of the gastrointestinal tract. The disorder is characterized by a principal symptom of abdominal pain. Abdominal bloating is another common symptom. These symptoms are associated with various changes in bowel habits, predominantly diarrhea or constipation, though some cases experience both or alternate between the two. Importantly, there is an absence of certain alarm signs or symptoms including unintentional weight loss, anemia, bloody stools, new onset at 50 years of age and family history of colon cancer, IBD, or celiac disease. Presence of any of these red flags may indicate a disease other than IBS such as colon cancer or IBD. Manifestations. 1. IBD. UC onset is frequently insidious with increasing stool urgency and frequency. In addition to urgency, bloody stool and mucus in the stool can also gradually increase. The typical course of UC can be generalized as bouts of varied disease intensity interspersed with asymptomatic periods. CD onset is typically insidious but can present as severe or fulminate disease. Further, there may be patterns of symptoms, which relate to disease location as well as type, inflammatory, fibrostenotic, or fistulizing, for example, which can be useful in determining therapy decisions. 102. IBS. IBS can be characterized by pain relieved by defecation, alternating bowel habits, abdominal distension, mucus in the stool, and a sensation of incomplete defecation. IBS usually occurs as either constipation predominant IBS or diarrhea predominant IBS. 908 Chapter 45 B. Constipation predominant IBS-C tends to present with pain and periodic constipation alternating with normal periods of bowel function. Pain has been described as colicky, periodic, and/or as a continuous dull ache. Defecation may relieve the pain and eating can commonly trigger symptoms. Other common symptoms are bloating, nausea, dyspepsia, flatulence, and heartburn. Diarrhea predominant IBS-D is commonly characterized by precipitous diarrhea occurring immediately on rising or during meals or immediately postprandially. Nocturnal episodes are rare. Other common presenting complaints are pain, bloating, rectal urgency, and incontinence. Mixed pattern IBSM is used to describe cases where predominant symptoms include both diarrhea and constipation. Alternating pattern OBSA is used to describe cases where predominant symptoms alternate from constipation to diarrhea over a period. Epidemiology of IBD. It has been estimated that more than 1 million Americans have IBD, and that roughly half have UC and half have CD. 1. UC incidence and prevalence rates have remained relatively constant in North America and Northern Europe and appear to be increasing in Southern Europe and East Asia. UC historically has been more common than CD. UC incidence rates in North America range between 9 and 12 cases per 100,000 patients. Recent prevalence rates for UC in North America are reported to be 205 to 240 per 100,000 patients. Rates are comparable in Northern European countries. B. UC incidence and prevalence rates are lower in Southern Europe, Asia, and Central South America. 102. CD incidence and prevalence rates have seen a marked rise since the early 1950s. There's a great variance in published incidence rates of CD. Areas of higher CD incidence are generally similar to those of higher UC incidence. CD has become more common than UC in some areas recently. Reported CD incidence rate for North America ranges between 6 and 8 cases per 100,000 patients. CD prevalence rates in North America are estimated to be 100 to 200 cases per 100,000 patients. CD rates for Northern Europe are comparable to those in North America. B. Rates for Southern Europe, Asia, and Central South America have been reported to be lower than those seen in North America and Northern Europe. 3. Geographic-related components. Northern regions have historically reported higher rates of IBD than southern regions. Rates in Southern Europe have recently seen increasing incidence rates compared to historical rates. B. CD rates have been reported to be higher in urban areas. C. UC rates have been reported to be higher in rural areas. D. IBD rates have historically been higher in developed countries compared to underdeveloped countries. This difference has been shown to decrease as underdeveloped areas are developed, and a more Western diet is adopted. 4. Ethnic, racial, and socioeconomic components. A. IBD, CD in particular, development risk is higher in Jews of European descent than non-Jews. While IBD prevalence is reported to be higher in Jews compared to non-Jews, there is considerable variation within Jewish populations from different geographic locations. B. Non-Jewish whites historically have been considered to be at higher risk for IBD compared to African Americans, but that difference has been questioned in recent published reports. Blacks in Africa tend to be at less risk for IBD than either North American Caucasians or African Americans. C. Asians appear to be at lower risk for developing IBD than Caucasians, but migrant Asians to the United Kingdom, interestingly, have been shown to be at higher risk for UC and nearly equal risk of developing CD compared to UK-born Caucasians. D. Incidence rates of IBD have historically been reported to be higher in higher socioeconomic classes. 5. Age and sex-related components. A. IBD is more common in young adult patients than older patients with peak age of onset between 15 and 30 years. B. Men and women are at similar risk to develop IBD, with women having a slightly higher risk to develop CD and men a slightly higher risk of developing UC. Diseases of the bowel. Inflammatory bowel disease and irritable bowel syndrome. 909. 6. Other contributing factors. A. Smoking has been associated with a decrease in UC rates, roughly 60% of rates seen in non-smokers. But the risk factors to general health do not warrant foregoing counseling patients on the benefits of smoking cessation. B. Former smokers are at increased risk of developing UC. C. Smoking has been shown to be risk factor for developing CD, more than 1.75 times the rate seen in non-smokers. CD patients who actively smoke also have increased morbidity compared to CD patients who stop smoking. D. Appendectomy has been shown to be protective with regard to development of UC. E. Use of oral contraceptives has been associated with increased risk of developing IBD. 7. Genetic predisposition to IBD is another area of recent research advances. Genetic predisposition to IBD is suggested by, among other factors, epidemiologic studies, studies of twins, family aggregation studies, and ethnic differences in disease patterns. The CARG15 NOD2 genetic mutation, for example, is seen more often in CD than in the general population. The mutation has been associated with altered immune response to bacteria. There are limitations to CARG15 usefulness in clinical practice, but the identification of this mutation and others has opened the door for more work around genetic predisposition and possible disease mechanism. These may lead to new modes of therapy. D. Epidemiology of IBS. 1. IBS is reported to be more common in women than men. 2. IBS usually presents between the ages of 30 and 50, with significant decreases at ages greater than 50. 3. Prevalence seems to be equal in Caucasians and blacks and less in Hispanics. Overall prevalence rates are estimated at 7% to 15% of the U.S. population. 4. IBS appears to be as common in Asian, South American, and India as in Western countries. E. Description. 1. UC is chronic recurring mucosal inflammation of the colon. A. Proctitis. Inflammation of the rectum. B. Proctosigmoiditis. Colitis affecting the rectum and sigmoid colon. C. Left-sided colitis. Disease starting at the rectum and extending retrograde to the splenic flexure of the colon. D. Pancolitis. Disease affecting the entire colon. E. Backwash ileitis. Inflammation of the terminal ileum due to retrograde flow of colonic contents in pancolitis patients too. CD is chronic recurring transmural inflammation of the gastrointestinal tract. Ileocolitis, the most common form of CD, affecting the ileum and colon. B. Ileitis. CD affecting the ileum. C. Gastroduodenal Crohn disease. CD affecting the stomach and duodenum. D. Jejunoileitis. CD producing inflammation of the jejunum and ileum. E. Crohn granulomatous colitis. CD affecting only the colon. 3. IBS-A. IBS is recognized as being part of functional bowel disease. B. IBS is characterized by symptoms of abdominal pain or discomfort that is associated with disturbed defecation patterns. IBS is typically of a constipation predominant, IBS-C, or diarrhea predominant, IBS-D, type with a minority of patients alternating between the two, IBS-A, or of a mixed presentation. Etiology. 1. IBD is thought to be caused by a poorly understood compilation of environmental, genetic factors, and possibly infectious agents. IBD is likely a result of multiple environmental factors eliciting an abnormal immune response in genetically susceptible individuals. There is significant overlap between the clinical presentation of UC and CD, the two main idiopathic inflammatory disease states, which make up IBD. And as such, clear differential diagnosis between UC and CD is not always possible. A. There is clear evidence of immune system activation with subsequent infiltration of the tissue by lymphocytes, macrophages, and other cells. The exact trigger of this apparent poorly regulated immune response has yet to be defined. 910 Chapter 45 I. F. B. Possible mechanisms postulated for IBD disease initiation include virus or bacterial infection. dietary antigens or inappropriate immune response to normally non-antigenic microbes, and the possibility of an inappropriate immune response to intestinal autoantigens expressed on the intestinal epithelium. C. Regardless of cause, there appears to be failure of normal suppressor mechanisms with a resultant overly vigorous and abnormally long immune response to a disease trigger. D. IBD occurs 30 to 100 times more frequently in first-degree relatives of IBD patients compared to the general population. E. Infectious colitis can mimic IBD. Differential diagnosis includes bacterial, protozoal, and viral pathogens, notably Clostridium difficile, fungal, protozoal, viral, and helminthic pathogens. If ischemic colitis and neoplastic diseases such as Sickle adenocarcinoma, lymphoma, and metastatic cancers may also present like IBD. G. Microscopic colitis and other inflammatory diseases such as celiac sprue and eosinophilic colitis can present in much the same manner as IBD. H. Drug-induced enterocolitis can induce IBD-like symptoms. The most commonly implicated classes of drugs are nonsteroidal anti-inflammatory drugs, NSAIDs, gold compounds, oral contraceptives, enteric potassium supplements, pancreatic enzymes, phospho-soda bowel preps, and thermal injury secondary to colostomy irrigation. I. Other possibly confounding diseases include endometriosis and diverticular disease. 2. IBS-A. The exact cause of IBS is unknown and no anatomic cause has yet to be elucidated. B. Possible comorbid factors such as viral or bacterial gastroenteritis, emotional health, diet, environmental, concurrent drug therapy, and hormones have been implicated in GI dysmotility. C. Anxiety disorders, particularly panic disorder, major depressive disorder, and somatization have also been implicated as possible initiating factors for IBS. D. Learned aberrant illness behavior, where patients may tend to express emotional conflict as a GI complaint, usually abdominal pain, may also be a contributing disease state. The clinician evaluating patients with IBS, particularly those with refractory symptoms, should investigate for unresolved psychological issues, including the possibility of sexual or physical abuse. G. Pathophysiology 1. IBD-A. UC. Physiologic changes in UC begin with edema followed by loss of fine vascular pattern and increased mucosal friability. Ulceration, exudates, and pseudopolyps may also be present. With longer disease history, the colon may begin to become featureless and tubular in nature. UC tends to occur in a contiguous manner. B. CD. Inflammation and subsequent injury of tissue known as cryptitis leads to crypt abscess and subsequently focal aphthoid ulceration. The inflammatory process can progress with influx and proliferation of macrophages and other inflammatory cells. Transmural inflammation may lead to lymphedema and bowel wall thickening. This thickening can lead to fibrosis. Affected areas are usually sharply demarcated from normal adjacent tissue and give rise to the skip lesion appearance of CD. 2. IBS-A. Abnormalities in intestinal motility in IBS appear to be related to underlying muscle dysfunction, as well as hyperactive response to initiating factors such as food or parasympathomimetic drugs. B. Abnormal increases in frequency and amplitude of contractions can lead to functional constipation, while diminished motor function of the underlying musculature can lead to diarrhea. C. Hypersensitivity to normal amounts of intraluminal distension exists, as does a heightened perception of pain in the presence of normal quantity and quality of intestinal gas. D. The pain of IBS may be caused by abnormally strong contraction of the intestinal smooth muscle or by increased sensitivity of the intestine to distension. Disease of the bowel, inflammatory bowel disease and irritable bowel syndrome 9111. E. Hypersensitivity to the hormones gastrin and cholecystokinin may also be present. However, hormonal fluctuations have not correlated with clinical symptoms. F. The caloric density of food intake may increase the magnitude and frequency of myoelectrical activity and gastric motility. Fat ingestion may cause a delayed peak of motor activity, which can be exaggerated in IBS. G. The first few days of menstruation can lead to transiently elevated prostaglandin E2, resulting in increased pain and diarrhea. H. Clinical presentation 1. UC. Most patients will present with symptoms related to altered stool frequency, bowel sensation, and abdominal pain. A. Most UC cases begin as mild disease and worsens as the disease course progresses. B. UC usually follows a chronic, intermittent course. C. Quiescent periods tend to be long with acute attacks interspersed. D. Attacks or flares can last weeks to months. E. Some patients suffer from continuous disease. F. Severe UC can result in toxic megacolon, a life-threatening condition. G. Elderly patients can rarely present with constipation secondary to rectal spasm. H. Typical presenting symptoms of UC are as follows. 1. Increased stool frequency. 2. Hematochezia. 3. Tenesmus. 4. Lower left quadrant pain. 5. Nausea, vomiting. And weight loss, usually only in severe disease. I. Extraintestinal manifestations of UC. 1. Arthralgias. 2. Ankylosing spondylitis. 3. Pyoderma gangrenosum. Erythema nodosum. 4. Aphthous ulcers. 5. Uveitis and uveitis 2. CD. Many patients present with acute symptoms mimicking appendicitis or intestinal obstruction. CD can be exacerbated by infections, smoking, and NSAID use. While not well correlated in controlled trials, stress is often implicated by patients and family members as a contributing factor. A significant number of patients have a history of perianal disease, especially fissures and fistulas, which are sometimes the most prominent or even initial complaint. B. Extraintestinal manifestations can be more prominent than GI symptoms in pediatric patients. C. Typical presenting symptoms of CD are as follows. 1. Abdominal pain. 2. Diarrhea. 3. Weight loss. 4. Fever. D. Extraintestinal manifestations of CD. 1. Arthralgias. 2. Acute peripheral arthritis. 3. Ankylosing spondylitis. Peripheral arthritis. 4. Erythema nodosum. Pyoderma gangrenosum. Sweet syndrome. 5. Iridocyclitis. Uveitis and episcleritis 3. IBS. IBS symptoms are frequent in patients with active disease. B. Symptoms may be classified with either the new Rome III criteria or may still be classified with the Rome II criteria, which center around bowel movement and abdominal pain. The clinical symptoms are the same regardless of how they are classified. 1. Abdominal pain has been characterized as crampy, localized to the lower left abdomen with variable intensity. Patient presentation is highly variable with regard to intensity, location, and duration of pain. Some women will have exacerbations coinciding with menstrual periods. 912 Chapter 45 I.H. Alteration of bowel habits is the second major identifying symptom of IBS. They include diarrhea, constipation, mixed, and alternating diarrhea and constipation. 3. IBS can also present with bloating, gas, belching, heartburn, reflux disease, achalasia, early feeling of fullness on eating and nausea, painful menstruation, sexual dysfunction, and frequent or urgent urination. C. IBS tends to wax and wane over the long term, with patients having acute bouts of disease interspersed with periods of no disease. While total prevalence numbers remain relatively constant, studies of defined patient populations at various periods show the same number of active patients, but the individual patients may be different. First, clinical evaluation 1. IBD differences in typical clinical presentation between UC and CD are summarized in Table 45-1. A. UC. Patient symptoms are usually the first signs of disease. Diarrhea, bleeding, tenesmus, mucus in the stool, and pain are the most common. 2. The severity of symptoms correlates with disease severity. Acute disease can be associated with increased C-reactive protein, platelet count, erythrocyte sedimentation rate, R, and a decrease in hemoglobin. 4. Serum albumin can fall quickly in severe disease. Sigmoidoscopy can be useful for assessing disease severity and extent before therapy. Care must be used in severe disease as risk of perforation is increased. B. UC disease classification according to extent, distal versus extensive, and severity is of use in determining therapy. 1. Mild UC has been defined as less than 4 stools per day with or without blood, normal ESR. 2. Moderate UC has been defined as more than 4 stools per day, but minimal signs of toxicity, fever, tachycardia, anemia, or elevated ESR. 3. Severe UC has been defined as more than 6 bloody stools per day. Evidence of toxicity is demonstrated by fever, tachycardia, anemia, or elevated ESR. Elevated ESR is not always present, even in the most severe UC. Table 45-1 differences of UC and CD. UC-CD. Abdominal pain, infrequent bloody diarrhea, frequent occasional perianal involvement, rare frequent perianal fistula, rare frequent rectovaginal fistula, rare common fever, occasional frequent weight loss, occasional frequent palpable mass, rare common intra-abdominal abscess, rare common bowel obstruction, rare common antibiotic response, rare frequent skip lesions, rare frequent contiguous disease, frequent infrequent effect of smoking, often improves UC, often worsens CD serologic markers. Diseases of the bowel. NFL inflammatory bowel disease and irritable bowel syndrome 913. 4. Fulminate UC has been defined as more than 10 bowel movements, continuous bleeding, toxicity, abdominal tenderness and distension, need for blood transfusion, and colonic dilation, toxic megacolon. In addition to classifying UC as mild to fulminate, it is useful to ascertain the impact the disease is having on patient activity with a global assessment approach including extraintestinal manifestations, ocular, oral, joint, skin, moods, general health, laboratory evaluation for anemia, liver function tests, quality of life, impairment at work or school, interpersonal relationships. CT 1. CD patients may present with elevated ESR, C-reactive protein, and, in more severe disease with hypoalbuminemia, anemia, and leukocytosis. 2. CD can occur throughout the bowel and site of disease affects disease course and treatment choices. 3. Ileocolitis is the most common form of CD. It has been characterized by right lower quadrant pain, diarrhea, and can mimic acute appendicitis. Pain can be colicky and usually precedes defecation and is relieved by defecation. 4. Jejunoileitis. Extensive inflammation can lead to loss of absorptive surfaces with resultant malabsorption and steatorrhea. This malabsorptive state can lead to dietary deficiency, hypoalbuminemia, electrolyte imbalances, coagulopathy, and increased risk of bone fractures. Colitis patients tend to present with low-grade fever, diarrhea, vomiting, and epigastric pain. 6. Perianal CD patients may present with incontinence, stricture, anorectal fistula, and perirectal abscess. D. CD classification based on severity and location is useful for determining therapy. 1. Mild to moderate disease has been used to define CD in patients who are ambulatory, able to take food orally, no symptoms of dehydration, no signs of toxicity, high fever, rigors, prostration, no abdominal tenderness or painful mass, no obstruction, or weight loss 10%. 2. Moderate to severe disease describes patients who have failed to respond to therapy for mild to moderate disease or patients with more prominent symptoms of fever, significant weight loss, abdominal pain or tenderness, intermittent nausea or vomiting without obstruction, or anemia. 3. Severe to fulminant disease describes patients with persisting symptoms despite therapy with steroids as outpatients, or patients with high fever, persistent vomiting, obstruction, rebound tenderness, cachexia, or evidence of abscess. 4. Remission refers to patients who have responded to acute medical therapy or who are post-surgical intervention without gross evidence of residual CD. Patients who require steroids to maintain control of CD are considered steroid-dependent and are not considered to be in remission. CD disease location is often classified as being ileocolic, small bowel, colonic, or anorectal. The Vienna classification of disease location and type of CD is also often used. CD type is recognized to change with regard to type and location during disease course. A. Terminal ileum disease is CD in less than 1/3 of small bowel, with or without spillover into the cecum. B. Colon CD is colonic involvement anywhere from the cecum to the rectum without small bowel or upper gastrointestinal disease. C. Ileocolon is CD of the terminal ileum and any location between the ascending colon and rectum. D. Upper GI CD is disease in any location proximal to the terminal ileum, with or without involvement distal to the terminal ileum. E. Type of disease is described as inflammatory, stricturing, or penetrating. 6. The Crohn's Disease Activity Index, or CDAI, is a validated measurement tool used to assess clinical improvement. The CDAI is a complete scoring system of subjective aspects. 914, Chapter 45, I, and objective observations. It is not normally used in clinical practice but is extensively used in clinical research. Crohn's disease severity, as defined by the CDAI, breaks down into the following stratifications. A score of 150 or less is considered clinical remission. B. A score of more than 150 up to 450 is considered mild to moderate disease. C. A score of over 450 is considered severe disease. 2. IBS-A. Diagnosis of IBS commonly includes identifying positive symptoms by medical history. This can be guided by older Rome II criteria or the recently published Rome III criteria. Physical exam is also done to exclude non-IBS disease, abdominal mass, palpable liver, etc., as the majority of IBS patients do not have these physical abnormalities. Both patient history and physical exam are also needed to exclude IBD and microscopic and eosinophilic colitis, which can present in similarly to IBS. B. Rome II diagnostic criteria for IBS: 1. At least 12 weeks, which need not be consecutive. In the preceding 12 months of abdominal discomfort or pain that has 2 of 3 features. A. Pain relieved by defecation, and/or B. Pain onset associated with a change in frequency of stool, and/or C. Pain onset associated with a change in form, appearance of stool. 2. Symptoms that cumulatively support the diagnosis of IBS. A. Abnormal stool frequency. For research P. Purposes, abnormal may be defined as greater than 3 bowel movements per day and less than 3 bowel movements per week. Lumpy abnormal stool form, lumpy hard or loose watery stool. C. Abnormal stool passage. Raining, urgency, or feeling of incomplete evacuation. Z. Passage of mucus, and bloating or feeling of abdominal dis. The diagnosis of a functional bowel disorder, IBS, always presumes the absence of a structural or biochemical explanation for the symptoms. C. Rome III diagnostic criteria for IBS: recurrent abdominal pain or discomfort at least 3 days per month in the last 3 months associated with 2 or more of the following. A. Improvement with defecation. B. Onset associated with a change in a frequency of stool. C. Onset associated with a change in form, appearance of stool. 2. Criteria fulfilled for the last 3 months with symptoms onset at least 6 months prior to diagnosis. 3. Discomfort means an uncomfortable sensation not described as pain. 4. In pathophysiology, research, and clinical trials, a pain and discomfort frequency of at least 2 days a week during screening. Evaluation for subject eligibility. D. Routine blood testing is normal in most suspected IBS patients and helps rule out other possible diagnoses. E. Sigmoidoscopy and colonoscopy are done to visualize the bowel when clinically appropriate to exclude other possible diagnoses. J. Treatment objectives. 1. IBD-A. Induce remission with control of acute inflammatory flare. B. Maintain remission as long as possible. D. Normalize bowel function when possible. E. Maintain nutritional status. B. Improve quality of life. 2. IBSA. Alleviate discomfort. B. Normalize bowel habits. C. Minimize negative impact on patient. Diseases of the bowel. Inflammatory bowel disease and irritable bowel syndrome 915. Second therapy. Overview of agents used in IBD. 1. Aminosalicylates are generally considered to be effective therapy of UC, but are of little to no benefit for CD. The commercially available agents all deliver the active mesalamine or 5-aminosalicylic acid, 5-ASA moiety. The oldest agent, sulfasalazine, zolfidine, contains a 5-ASA molecule bound to sulfapyridine. This bond is cleaved by intestinal flora to release the active compound 5-ASA. Newer agents, enteric-coated mesalamine, osalazine, balsalazide, have been developed to allow dosing without the sulfapyridine moiety, which has been implicated in many of the common adverse events and intolerances to sulfasalazine. Sulfasalazine is considered by many to be the first choice due to longer history of use, more convincing clinical trial data, and lower cost. Disadvantages of sulfasalazine are increased incidence of adverse events. Topical 5-ASA has been added to oral 5-ASA with improved response and time to response. Mechanism of action. The effectiveness of 5-ASA can be attributed to its anti-inflammatory properties through varied mechanisms including blockade of the inflammatory mediators interleukin-1 and tumor necrosis factor alpha, TNF, as well as modulation of peroxisome proliferator activated receptor, PAR, colonic. Inflammation is reduced. Though 5-ASA differs from salicylic acid by the addition of an amino group, 5-ASA drugs retain some variable effects on prostaglandin and prostacyclin synthesis that may be beneficial in IBD as well. B. Administration and dosage. There are currently several 5-ASA derivatives available, Table 45-2. Dosages in UC are based on disease location, severity, and overall patient condition. Enteric-coated or sustained-release products should not be crushed or chewed. Table 45-2 aminosalicylates. Delivery. Drug trade strength dosing max. Formulation site. Oral sulfasalazine azulfidine 500 mg tab 1000 mg T. Per drug sulfapyridine, 6 grams day, 5-ASA. Azulfidine 500 mg tab 1000 mg T. I. Per drug sulfapyridine, in tab 6 grams day, 5-ASA enteric. Coated. Balsalazide colazole 750 mg cap 2250 mg T. Per drug 4-aminobenzoyl 675 meters day. Alanine. Ulsalazine dipentum 250 mg cap 500 mg BID. Per drug 5-ASA. 5-ASA 3 gm day. Delayed release mesalamine 400 mg tab 800 mg T. ID. Eudragit S pH sensitive distal ileum. Asacol HD 800 mg tab. 4.8 grams day. Coding Mesalamine apreso 375 mg cap 1500 mg cubed. Enteric code, polymer matrix. Mesalamine Lialda 1000, 200 mg tab 2400 mg cubed. multimatrix system : 4 to 8 grams day. Sustained release mesalamine pentasa, 250 mg cap, 1000 mg q. Ethyl cellulose granules stomach, 500 milligrams cap : topical mesalamine rawasa 4 gm 60 milliliters suspension for rectal rectum. Susp administration splenic, ethyl exur, mesalamine canasa 500 milligrams suppository rectum, 1000 milligrams sup. 5 ASA, 5 aminosalicylic acid. 916 Chapter 45 2. C. Precautions and adverse effects. 1. Sulfasalazine. The most common adverse events are fever, dizziness, headache, itching, rash, photosensitivity, GI upset, nausea, vomiting, diarrhea, reversible oligospermia, and less commonly, Stevens-Johnson syndrome, Lyell syndrome, granulocytopenia, leukopenia, thrombocytopenia, aplastic anemia, hemolytic anemia, and hepatitis. Intolerance of the sulfapyridine moiety of sulfasalazine is common and is implicated in many adverse events associated with sulfasalazine. Sulfasalazine can interfere with the absorption of folic acid. Thus, it is advisable for such patients to take folic acid supplements. 2. Mesalamine osalazine balsalazide. The most common adverse events are diarrhea, headache, abdominal pain, cramps, flatulence, and less commonly skin rash. Rarely more serious side effects such as hepatotoxicity or acute or chronic renal injury have been reported. D. Significant interactions. The aminosalicylates may increase risk of toxicity and leukopenia when given in combination with mercaptopurine by decreasing mercaptopurine clearance. 5 ASA drugs have also been associated rarely with exacerbation of IBD. Concomitant use of antacids or acid-lowering agents may affect release characteristics of some of the formulations. 102. Steroids. Steroids are useful for patients refractory to 5 ASA or patients with severe symptoms requiring rapid control. A. Systemic corticosteroids are effective treatment for acute UC and CD. Use as maintenance therapy for IBD is normally avoided as the risk of systemic adverse effects outweighs limited benefit. Steroid dependency. When a patient is unable to be tapered completely off of steroids, does occur and should not be confused with maintenance. B. Topical and non-systemic steroids in the form of enemas, suppositories, and ileal release formulations have been effective in treating IBD. The rectally delivered topical formulations of steroids are of particular use in left-sided disease. Budesonide Intocort is an oral steroid delivered in a controlled-release formulation which acts in a topical manner owing to very high first-pass metabolism by the liver. Budesonide has been shown to be effective in acute IBD when the targeted release formulation is able to reach the site of disease. C. Mechanism of action. The glucocorticoid and mineralocorticoid effects of the steroids used in IBD are wide-ranging. The anti-inflammatory effects are likely due to glucocorticoid suppression of pro-inflammatory cytokines. D. Precautions and adverse effects. Therapy with oral and intravenous corticosteroids produce systemic effects, can impact multiple organ systems, and should be closely monitored for adverse events. 1. Adverse effects of steroids and IBD therapy are related to dose and length of dosing, and are the typical glucocorticoid and mineralocorticoid effects seen with exogenous steroid therapy. 2. Systemic steroids are more prone to inducing adverse effects. Topical delivery and targeted delivery of low bioavailability steroids have been developed to reduce the risk of adverse effects. 3. Minimizing duration of therapy as well as tapering patients off of systemic steroids are also methods of minimizing adverse effects as much as possible. 3. Azathioprine, Imurin, and 6-mercaptopurine, 6-MP, Purantol are effective at inducing and maintaining remission in IBD. Response is slow and may take months to be fully effective. 6-MP or azathioprine are effective for patients who do not respond to oral steroids but are not so acutely ill so as to require IV therapy. Mechanism of action. Azathioprine and 6-MP are purine antimetabolite drugs, which interfere with DNA synthesis, with disruption of the inflammatory response seen in IBD. B. Dosing and administration. There is no metabolic differences with regard to thiopurine methyltransferase, TPMT activity, which can lead to toxicity in patients with low or absent TPMT activity. Testing for TPMT phenotype can be useful in initial dosing. Consensus on the value of monitoring of metabolite levels during therapy has not been reached. Monitoring complete blood counts 4 weeks after starting therapy and then monthly during. Diseases of the bowel. Inflammatory bowel disease and irritable bowel syndrome, 917. Therapy should be done to monitor for toxicity. Azathioprine is 50% 6-MP by molecular weight, and equivalent doses are twice that of 6-MP. C. Precautions and adverse effects. Bone marrow suppression. Both azathioprine and 6-MP have been implicated in increased risk for Epstein-Barr-related non-Hodgkin lymphoma. This risk appears to be small but is serious. 4. Methotrexate, Rumitrex, given parenterally is an effective treatment for inducing remission, maintaining remission, and steroid-sparing in CD. Parenteral methotrexate is also effective for maintaining remission in CD. Methotrexate appears to be of little use in UC. Mechanism of action. Methotrexate is a folate analog and inhibits dihydrofolate reductase with multiple modes of anti-inflammatory effects. B. Dosing and administration. A 25 mg intramuscular, instant message, weekly has been shown to be effective for inducing remission of active CD. 15 mg instant message weekly has been shown to be effective at maintaining remission and as steroid-sparing therapy. Oral methotrexate 12.5 to 25 mg per week does not appear to be as effective as parenteral dosing. C. Precautions and adverse effects. Methotrexate is a known teratogen and should be avoided or used with extreme caution in patients of childbearing age, female and male, and only when all other therapies have been ineffective and the patients understand the risks involved. The doses used in CD are lower than those used in oncology, and the adverse events seen are generally less severe. The most common risks are rash, nausea, pneumonitis or mycoplasma pneumonia, and elevated serum transaminases. CD patients treated with methotrexate appear to be at low risk for hepatic toxicity. It is important to avoid alcohol consumption as it can increase the risk of hepatic toxicity in CD patients on methotrexate. 5. Cyclosporin oral and tacrolimus prograf are potent immunosuppressive agents that have been shown to be effective in IBD. They are typically used for severe acute IBD, as there is little data to support efficacy in mild disease to offset the potential toxicities of these agents. Mechanism of action. Both cyclosporin and tacrolimus are calcineurin inhibitors and are potent inhibitors of T lymphocyte activation. B. Dosing and administration. Before therapy is initiated, patients should be screened for potential drug interactions, normal renal function, cholesterol levels, blood pressure, and electrolyte status to help avoid toxicity. 1. Cyclosporin is started IV at 2 to 4 mg/kg day and titrated to levels of 250 to 350 nanograms cml. Tacrolimus is initiated at 0.1 to 0.15 mg/kg by month and titrated to trough concentrations of 10 to 15 nanograms cml. 3. Patients who respond are discharged on oral drug. Oral cyclosporin is dosed at twice the IV dose divided b. Ethiopiprine or 6-MP is added as soon as possible and oral systemic. Steroids are often given concomitantly also for 3 to 4 months. Cyclosporin and tacrolimus are normally stopped at 3 to 4 months. A steroid taper is also started at 3 to 4 months and should be done over 4 to 8 weeks. C. Precautions and adverse events. Cyclosporin and tacrolimus both have short and long-term adverse events that can be serious. The most commonly seen in IBD patients are paresthesias, hypertension, hypertrichosis, renal insufficiency, infection, gingival hyperplasia, and seizure. Patients should be closely monitored for effects on blood pressure, electrolytes, renal function, and cholesterol. Hypocholesterolemia and hypomagnesemia increase the risk of seizure. D. Significant interactions. Cyclosporin and tacrolimus are substrates of cytochrome P4000, 503A4 and P-glycoprotein enzymes. Significant and harmful alterations in cyclosporin and tacrolimus blood concentrations have been described as a result of concomitant administration of drugs that are also substrates or modifiers of these enzymes. Care must be used in concomitant dosing of these agents with other drugs that can adversely affect renal function such as NSAID. Cyclosporin has been noted to increase methotrexate and methotrexate metabolite concentrations. 6. Biologics. Infliximab, Remicade, adalimumab, Humira, and certolizumab pegol, Cimzia, are currently the main biologic therapies used in IBD. Table 45-3. These agents are anti-tumor necrosis factor alpha, anti-TNF antibodies. All three agents are indicated for inducing and 918 Chapter 45-2. Table 45-3 Biologic therapies of note in IBD. Drug trade mechanism efficacy in IBD. Adalimumab Humira fully human agon effective in CD. Monoclonal antibody to TNF. Infliximab Remicade chimeric mouse human agon effective therapy in CD and UC. Primary biologic. monoclonal antibody to TNF therapy used in IBD. Certolizumab Cimzia humanized pegylated Fab approved for CD in April 2008. Effective in CD. Pego fragment TNF antibody natalizumab tizobri humanized AG4 monoclonal removed from U.S. market in 2005 secondary. Antibody to 4-integrin that to association with progressive multifocal selectively inhibits leukocyte leukoencephalopathy. VURP. Natalizumab was adhesion made available again in 2006 via a restrictive company-administered access program. Place in therapy is yet to be fully elucidated, and the benefit must clearly outweigh the risks. Etanercept umbrella is of 75 soluble TNF receptor not of benefit. Fc fusion protein that binds TNF. CD, Crohn's disease, Ig, immunoglobulin G, TNF, tumor necrosis factor, UC, ulcerative colitis, FC, please spell out, IBD, inflammatory bowel disease, maintaining clinical remission of CD. Infliximab is also indicated in treating enterocutaneous and enterovaginal fistulae and maintaining remission of fistulizing CD. Infliximab is also effective in acute and quiescent UC. A fourth biologic agent, natalizumab tizobri, is a humanized monoclonal antibody directed at 4-integrin on the surface of white blood cells. It is approved for use in CD as well as multiple sclerosis. Anti-TNF therapy mechanism of action. Tumor necrosis factor alpha, TNF, is a cytokine involved in multiple pro-inflammatory and proliferative pathways in IBD. These agents bind TNF, preventing its binding to cell surface receptors and subsequently decreases inflammatory cytokines and increasing apoptosis of activated T lymphocytes and monocytes. Infliximab is a chimeric mouse, human monoclonal anti-TNF antibody. It is made up of human IgG constant regions, human light chains, and monoclonal murine regions that recognize TNF. Adalimumab is a recombinant human IgG monoclonal antibody with human heavy and light chain variable regions and human IgG constant regions. Certolizumab pegol is a humanized Fab fragment of an anti-TNF monoclonal antibody that has been pegylated to increase half-life of the antibody. B. Dosing and administration. 1 infliximab initial dosing is 5 mg/kg in a 3-dose induction regimen of days 0, 2, and 6 weeks. Duration of therapeutic effect appears to be 8 to 10 weeks, and dosing every 8 weeks has been advocated following a response to initial dosing. Formation of antibodies to infliximab. ATI during infliximab use has been described. The presence of ATI may increase infusion-related adverse reactions, delayed type hypersensitivity reactions, and may decrease the effectiveness of infliximab therapy. Strategies to reduce ATI formation include a regularly scheduled maintenance regimen of infliximab versus episodic treatment, and the use of concomitant administration of azathioprine, 6-MP, or methotrexate. These immunosuppressant drugs have not been shown to improve clinical disease control when given concomitantly with infliximab. 2. Adalimumab is initially dosed 160 mg on day 1 as 4 40 mg injections on the first day or 2 40 mg injections per day for 2 days, followed by 80 mg 2 weeks later or at day 15. 2 weeks later, day 29, maintenance therapy is begun at 40 mg every other week. Formation of anti-adalimumab antibodies has been reported in 3% of patients. Certolizumab pegol is given as a 400 mg injection on day 0 and weeks 2 and 4. If response occurs, Dosing may continue with 400 mg every 4 weeks. Formation of anti-certolizumab antibodies has been reported in 8% of certolizumab-treated patients. Diseases of the bowel: inflammatory bowel disease and irritable bowel syndrome 919. C. Precautions and adverse effects. Anti-TNF therapies share similar precautions and adverse effect profiles. 1. Acute infusion or injection-related reactions can occur. Risk of such a reaction is greater through 22% with infliximab use than with adalimumab, 1% or certolizumab, rare. Severe anaphylactic reactions are rare. Delayed hypersensitivity reactions including myalgias, rash, fever, arthralgias, pruritus, edema, urticaria, sore throat, and dysphagia occur 3 to 12 days after infliximab infusion and are much less common at approximately 2% of patients receiving maintenance infliximab therapy. 3. All anti-TNF antibodies carry black box warnings for increased risk of opportunistic infections. For example, tuberculosis, invasive fungal infections such as histoplasmosis, blastomycosis, or pneumocystis, viral infections such as hepatitis B. Use of concomitant immunosuppressive agents may increase risk of infection. Patients should be tested for tuberculosis prior to use of these agents, and their use should be avoided or discontinued in the case of active infections. 4. All anti-TNF antibodies carry black box warnings for increased risk of lymphomas and other malignancies. Use of concomitant immunosuppressive agents may increase this risk. D. Antimonus 4-integrin antibody mechanism of action. Binding of the 4-integrin protein by natalizumab effectively interrupts normal leukocyte trafficking across endothelial layers to areas of inflammation. E. Antimonus 4-integrin antibody dosing. Natalizumab is given as an intravenous infusion of 300 mg every month. Availability of natalizumab is restricted. It is available only through entities registered with the TOUCH prescribing program. F. Antimonus 4-integrin antibody adverse effects. Common adverse effects include headache, arthralgia, and fatigue. More serious adverse effects include increased risk of opportunistic infections and acute hypersensitivity reactions. Prescribing information for natalizumab also carries a black box warning for increased risk of progressive multifocal leukoencephalopathy, or PML. There is no treatment for PML. Patients are to be monitored closely for symptoms so that natalizumab may be discontinued. Typical symptoms associated with PML include progressive weakness on one side of the body or clumsiness of limbs, and changes in vision, thinking, memory, and orientation. These lead to confusion and personality changes. PML symptoms progress over days to weeks. Concomitant use of other immunosuppressive agents such as azathioprine, 6-MP, methotrexate, and so forth is not advised due to increased risk of serious adverse effects. 7. Antibiotics. No specific infectious agent has been identified as the single causative factor in either UC or CD. A. Use of broad-spectrum antibiotics in IBD is limited to empiric treatment of fulminant disease or in patients with toxic megacolon, where short-term use of these antibiotics can be justified due to the increased risk of perforation or bacteremia. B. Use of select antibiotics such as metronidazole, Flagyl, ciprofloxacin, Cipro, clofazimine, Lamprine, or rifaximin, with the specific goal of remission of acute IBD is controversial. While few clinical trials in a recent meta-analysis indicate potential benefit, design limitations temper the strength of those findings. C. Metronidazole and ciprofloxacin are used widely by convention as maintenance therapy in CD, but controlled trial results do not conclusively support this use. D. Metronidazole has been useful in patients suffering from pouchitis post-bowel resection surgery that involves formation of a pouch. E. Metronidazole and ciprofloxacin both would appear to be of some benefit in treating patients with fistulous IBD. 8. Probiotic and prebiotic therapy. Probiotic involves using exogenously administered bacteria such as Lactobacillus GG, Saccharomyces boulardii, and non-pathogenic Escherichia coli, among others, in an attempt to normalize the intestinal environment flora and thus decrease inflammatory triggers. Controlled trials of probiotic therapy in IBD have yet to clearly define clinical utility. There is little evidence to support their use in acute IBD. However, recent meta-analyses suggest potential benefit of probiotics when combined with conventional therapies for MATE. 920, Chapter 45-2. Nance of UC but not CD. Remission maintenance of pouchitis with VSL number 3. A probiotic preparation of 4 lactobacilli strains and 3 bifidobacterium and 1 strain of streptococcus was shown to be of benefit. Prebiotics are orally administered substances like non-digested carbohydrates with the goal of facilitating growth of commensal gut flora to displace possible antigenic microorganisms. There is little data to support prebiotics at this time. 9. Antispasmodics and antidiarrheals. Cramping and abdominal IBS-like symptoms are often noted in IBD patients. Use of symptomatic therapies is not well defined in the published IBD literature, as most research is aimed at the inflammatory process. Once active inflammation is controlled or ruled out, anticholinergic antispasmodics are frequently used judiciously to treat cramping or discomfort in IBD inflammation, as are antidiarrheals in mild or quiescent disease. All of these agents should be avoided in serious disease, as they may further impair intestinal motility and increase risk of toxic megacolon. 10. Antidepressants and anxiolytics have been used when specific patient symptoms warrant their use as adjuvant therapy. Universal use of such therapies is not supported by available evidence. 11. Analgesics. There is rarely a need for pain control in UC, as the disease is limited to the mucosa of the colon with limited involvement of tissue containing pain receptors. Narcotics are to be avoided in UC therapy outside of perioperative situations, as they increase the risk of toxic megacolon and can mask signs of perforation. NSAID medications should be avoided as they have been implicated in inducing IBD flares. 12. Surgery. Surgical resection of the colon is considered curative in UC. Surgical resection of bowel in CD is not curative, as the disease will often recur at the resection site as well as other sites. Surgery in UC is most commonly indicated for disease refractory to medical therapy, inability to wean the patient off of high corticosteroid dosages, serious drug side effects or intolerance, and occurrence of premalignant or malignant changes in the colon. B. Approximately 1/3 of UC patients eventually undergo colectomy. Patients with extensive disease, pancolitis, undergo colectomy more than patients with less extensive distal disease and also usually require colectomy sooner than patients with less extensive disease. C. UC surgery can be divided into 2 types, those that preserve continence and those which do not, and subsequently require appliances to collect the fecal material. 1. Proctocolectomy with permanent ileostomy is the oldest procedure and involves formation of an abdominal stoma connected to the ileum. An external appliance is used to collect fecal material. 2. Proctocolectomy with continent ileostomy involves creation of a pouch inside the abdomen using the terminal ileum. A small leak-proof opening is created in the abdomen wall, and the pouch is periodically drained. 3. Colectomy with ileorectal anastomosis involves removing diseased large bowel and reattaching the remaining small intestine to a preserved rectum. While bowel movements via the rectum are preserved, patients are at risk of relapse as the rectum is often involved in UC. 4. Ileal pouch anal anastomosis (APA) is the most common surgical procedures done for IBD. The large bowel and rectum are removed, with preservation of the anal sphincter. A tubular pouch is formed from the small intestine and attached to the preserved sphincters, which allows bowel movements without external bags or appliances. A temporary ileostomy is often used during healing. CD surgery, while not curative, is required in a very high percentage of patients. Surgical intervention can be limited to specific areas of diseased bowel or total ileostomy or colectomy. Surgery is most commonly indicated in CD refractory to medical therapy, medication side effects, or steroid dependency. 1. Small bowel resection is preferred in most patients with ileal or ileocolic CD. Primary anastomosis versus ileostomy, permanent or temporary. Choice is based on patient status and CD severity. 2. Large bowel CD may require varying degrees of resection secondary to the typical CD disease course involving skip lesions. Primary anastomosis of preserved bowel may be preferred for patient cold reasons but has been linked to earlier reoccurrence of CD. 3. Colectomy with ileorectal anastomosis, while increasing risk of earlier CD recurrence, is useful in young patients where ileostomy may adversely affect colon. Diseases of the bowel. Inflammatory bowel disease and irritable bowel syndrome 921. 4. Proctocolectomy and ileostomy is preferred in patients with extensive perianal disease or pancreatitis CD. 5. Strictureplasty can also be useful in stricturing CD. Pouchitis is the most common complication of continent ileostomy and IPA. It has been characterized as a syndrome including acute nonspecific inflammation of the reservoir pouch formed during surgery with unknown etiology. 1. Idiopathic pouchitis must be differentiated from inflammation of the pouch due to anastomotic stricture and infection due to known pathogens. 2. Broad-spectrum antibiotics have been the main medical therapy used for pouchitis. Metronidazole and ciprofloxacin have both been effective for acute pouchitis and have also been used as maintenance therapy. 3. Probiotic therapy with VSL number 3 has been of benefit also. 4. Pharmacologic therapy used in IBD has been shown to be of mixed efficacy in pouchitis. Surgical revision may be required in chronic pouchitis unresponsive to medical therapy. 13. Other therapy. Nutritional issues are important to consider in IBD. While conclusive evidence does not exist showing particular foods cause IBD, special attention to diet in patients with IBD can be beneficial. 1. Nutritional and hydration deficiencies can occur secondary to a poorly functioning GI tract and the chronic nature of IBD. 2 foods that are known to exacerbate an individual patient's IBD should be avoided, and a well-balanced diet should be encouraged to maintain nutritional status. Restrictive diets are not normally required. Simply limiting offending foods while encouraging a balanced diet is usually sufficient to maintain nutritional status. Parenteral feeding is seldom used long-term in IBD, but can be useful to improve or maintain nutritional status in severely ill patients. B. Emotional factors. Due to the chronic nature of IBD, many sufferers have need for emotional support during the course of their disease. While IBD does not appear to be directly affected by emotional state, the QOL experienced by these sufferers can be noticeably affected in a negative manner. Many will benefit greatly by support groups, continued open dialogue with their healthcare providers, and in less common cases, formal counseling or pharmacologic therapy may be needed. B. Drug therapy of UC. 1. Classifying UC based on anatomic disease extent is useful for determining medical therapy. Distal disease below the splenic flexure can be treated effectively with topical therapy. Extensive disease extending proximal to the splenic flexure normally requires systemic therapy. Severity of acute UC is also useful in determining medical therapy. Severity is generally defined as mild, moderate, severe, or fulminate. 2. Management of acute mild-moderate UC distal disease. Patients with mild to moderate distal UC respond well to oral or topical 5-ASA or topical steroids for inducing remission, control of inflammation. A. Topical 5-ASA is superior to topical steroids or oral 5-ASA agents. B. Topical 5-ASA plus oral 5-ASA is superior to either alone. C. Topical 5-ASA may be effective in patients refractory to oral 5-ASA or topical steroids. D. Oral plus topical therapy consisting of oral mesalamine 2-4 grams day in divided doses plus mesalamine 4 grams day enema may induce remission of UC more quickly. E. Infrequently, oral corticosteroids may be needed in patients refractory to topical oral 5-ASA agents and topical steroids in maximal doses. See oral corticosteroids under mild to moderate extensive or relapsing disease. Therapy is largely determined by patient preference to therapy modality. G. Oral 5-ASA doses for inducing remission in mild to moderate distal disease. 1 sulfasalazine 3 to 6 grams day in 3. Divided doses. 2 mesalamine 2.4 to 4.8 grams day in divided doses where interval varies by product from 1 to 4 doses per day. See table 45-23, balsalazide 6. 75 grams day in 3 divided doses. 4 olsalazine 1 to 3 grams day in 2 divided doses. 922 Chapter 45-2. B. H. The oral 5-ASA drugs tend to work in 2 to 4 weeks and are effective in a high percentage of patients. I. Clinical efficacy of the different oral agents is very similar. Choice is then influenced by adverse effect profile and cost. J. Recent evidence suggests there is minimal benefit of 5-ASA oral doses greater than 2.4 grams day. K. Oral non-systemic corticosteroids. Budesonide is an oral corticosteroid that offers lower systemic exposure compared to prednisone secondary to high first-pass metabolism. Budesonide has been effective in UC treatment, but is limited to UC when the allele-release formulation can reach the location of disease. L. Topical therapy generally induces remission more quickly than oral therapy. Suppositories reach disease approximately 10 centimeters proximally. Foam products reach disease approximately 15 to 20 centimeters proximally. Enemas reach disease approximately to the splenic flexure. 52 to 56 centimeters. M. Topical 5-ASA for inducing and maintaining remission of UC. Mesalamine suppositories 1 gm day in 1 or 2 divided doses. Proctitis, 2 mesalamine enemas 4 grams day, distal. Colitis proximally to the splenic flexure, N. Topical corticosteroids for inducing remission of UC, 1 hydrocortisone enema 100 mg day. Hydrocortisone foam, 10% 1 application, 80 mg. Q to B. 3. Maintenance of distal disease. 5-ASA preparation dosages for maintaining remission of distal disease. 1. Balsalazide 3 to 6 grams day, 2 mesalamine 2 4 grams day. Mesalamine suppository 500 mg QD or B. Oparamine enema 2 4 grams daily. Every other day or every third day. Osalazine 1 gram day. Sulfasalazine 2 grams day. 7. Mesalamine 1.6 grams orally per day plus 4 grams enemas twice weekly is also effective. B. Dose reduction from amounts used during induction of remission of acute disease may be explored. Data suggest total daily doses of 5-ASA 2 grams are less effective than total daily doses 2 grams. C. Corticosteroids, topical or oral, are not effective in maintaining UC remission and should not be used. 4. Acute mild to moderate extensive or relapsing disease. A. Oral 5-ASA, sulfasalazine 4 to 6 grams day in 4 divided doses. Doses less than 2 grams a day appear to offer little benefit. 2. Newer 5-ASA preparations are generally considered to be equal to sulfasalazine with regard to efficacy, likely superior with regard to adverse events and tolerance, but are more expensive. The dosages used are a minimum of 2.4 grams day of active 5-ASA moiety titrated up to a maximum of 4.8 grams day. B. Oral steroids, 1 prednisone 40 to 60 milligrams day, modest efficacy gain with 60 milligrams compared to 40 milligrams until significant clinical effect is seen, followed by a dose taper of 5 to 10 mg weekly until a daily dose of 20 milligrams is reached. Tapering generally continues from here at 2.5 milligrams per week until the patient is weaned from oral steroids. 2. Higher doses for longer periods increase risk of corticosteroid-associated complications. 3. IBD patients receiving corticosteroids for greater than 3 months should be carefully monitored for presence of corticosteroid-associated complications such as hypertension, dyslipidemia, loss of bone mineral density, etc. 4. For patients on long-term corticosteroid, calcium supplementation at 1 to 1.5 grams a day and vitamin D supplementation at 800 milligrams a day should also be considered. 5. Maintenance of mild to moderate extensive or relapsing disease. Sulfasalazine is as effective as equivalent doses of newer 5-ASA agents and is less costly in long-term therapy. Systemic corticosteroids as a rule are not accepted as long-term therapy options secondary to adverse events and diseases of the bowel. Inflammatory bowel disease and irritable bowel syndrome 923. Questionable therapeutic effect. 6-MP or azathioprine has been useful as steroid-sparing agents and as long-term options to wean patients off of corticosteroids. Oral 5-ASA therapy. 1 balsalazide 3 to 6 grams day. 2 mesalamine 2 4 to 4.8 grams day. 3. Osalazine 1 gram day. Sulfasalazine 2 to 4 grams day. B. Immune modulators 1,6-MP 0.5 to 1.5 milligrams per kg once daily. Azathioprine 0.5 to 2.5 milligrams per kg once daily. Doses are titrated to keep white blood cell count 4,000 cells in. Patients with thiopurine methyltransferase (TPMT) deficiency are at excess risk of bone marrow suppression given usual doses of 6-MP or azathioprine. Allopurinol inhibits metabolism of 6-MP and azathioprine. 6-MP and azathioprine doses should be reduced with concomitant use of allopurinol. 6. Acute moderate to severe disease. UC patients with moderate to severe disease may or may not require hospitalization. Infection with enteric pathogens should be ruled out. 5-ASA should be stopped in the acute setting to avoid intolerance issues and the rare instances of 5-ASA exacerbating colitis. A. Corticosteroids. Intensive IV steroid therapy is indicated for patients with severe disease who are hospitalized. Doses with prednisolone 40 to 60 milligrams, hydrocortisone 300 milligrams, or methylprednisolone 32 to 48 milligrams a day in divided doses, or as continuous infusion have been shown to be effective. Higher doses are of limited benefit and increase risk of steroid toxicity. Patients with moderate to severe disease but not requiring hospitalization may be treated with oral doses on an outpatient basis. B. Biologics. 1. Infliximab was more effective compared to placebo. Reduced need for colectomy. For ambulatory patients refractory to or intolerant of systemic steroids. 2. Infliximab 5 mg per kg at 0, 2, and 6 weeks. ATI formation may be limited with concomitant dosing of azathioprine or 6-MP. 3. Other marketed anti-TNF antibodies may be effective in this role, however, studies are lacking. C. Immune suppressants. Failure to demonstrate significant improvement within 7 to 10 days is an indication for surgical resection or alternate IV therapy such as with cyclosporin. 1. IV cyclosporin at 2 to 4 milligrams per kg and titrated to blood levels between 200 and 400 nanograms per ml has been effective in a high percentage of patients who do not respond to maximal parenteral steroids. Oral cyclosporin at twice the daily IV dose is given in divided doses. B. With oral steroids once clinical remission is reached with IV cyclosporin. However, cyclosporin is not generally recommended for long-term maintenance due to significant adverse effects. B. Sulfamethoxazole trimethoprim, Bactrim, should be added as prophylaxis against pneumocystis pneumonia for patients on cyclosporin. C. Relapse on 5-ASA therapy alone after remission induced with cyclosporin is frequent, and azathioprine or 6-MP can be beneficial when added for maintenance. D. Topical steroids may provide benefit in patients with rectal urgency or tenesmus. E. Empiric broad-spectrum antibiotics are of little use for the treatment of moderate to severe UC. However, their use is justified in the case of proven bacterial infection. F. When possible, patients should be maintained on oral feedings with modified diet to reduce abdominal discomfort, diarrhea, and bowel frequency. Total parenteral nutrition is used when oral feeds are not tolerated and can be especially useful in patients with severe nutritional depletion. G. In patients with signs of toxicity, narcotics, antidiarrheals, and anticholinergics should be avoided as they can increase the risk of worsening colonic dilation and perforation. 7. Maintenance moderate to severe disease. A. Oral 5-ASA agents. As with mild to moderate disease, these agents have been shown effective in preventing disease relapse. 924 Chapter 45-2. B. Immune suppressants. 1. Azathioprine or 6-MP are modestly effective for patients who have failed or are intolerant of 5-ASA agents. Because of the delay in onset of effect, optimal results are seen when these agents are started during induction of remission and continued into maintenance the phase. C. Biologics. 1. Infliximab. In early studies, continued injections of infliximab at 5 mg/kg dose at 8-week intervals have been shown effective in remission maintenance compared to placebo for patients intolerant of 5-ASA, corticosteroids, or azathioprine or 6-MP. Use of infliximab and other anti-TNF antibodies in this capacity continues to be investigated. 8. Fulminant disease. Patients with fulminant colitis or toxic megacolon are treated as severe and generally kept on bowel rest. Broad-spectrum antibiotics are often used empirically due to high risk of perforation. Any worsening of disease is evidenced by radiologic, clinical, or laboratory changes while on medical therapy is an indication for immediate colectomy. C. Drug therapy of CD is dependent upon disease location, disease severity, and complications if present. Patients' response to initial therapy should be evident within weeks. Once control of acute disease occurs, consideration of maintenance therapy is warranted. Failure of continued symptomatic improvement or worsening of symptoms by 3 to 4 months necessitates reconsideration of chosen therapy. 1. Mild to moderate acute CDA. Budesonide orally, 1 targeted delivery to ileum. Works well in ileal or proximal colonic disease. 2. 9 mg day for 8 to 16 weeks. 3. Tapered 3 mg per week over 2 to 4 weeks. B. Oral broad-spectrum antibiotics have been used with limited controlled clinical data to support such use. 1. Possibly more beneficial in patients with primary colonic involvement. Atronitronidazole 750 to 1,500 mg day, metrofloxacin 1,000 mg day. C. If these therapies fail, the presentation can be considered refractory and treated as moderate to severe. D. Historically, 5-ASA products have been used to induce and/or maintain remission of mild to moderate CD. More recent analyses question the benefit of 5-ASA for these patients. 102. Moderate to severe acute CDA. Systemic steroids or an oral prednisone 40 to 60 mg day until symptom improvement weeks, then initiate a tapering regimen. 2. Hospitalization for IV corticosteroids may also be considered. B. Methotrexate 1 methotrexate 25 mg week instant message. Taper to 15 mg week instant message after 16 weeks. 2 methotrexate use trended toward improvement in remission of disease. Best results seen when given with corticosteroids. 3. Methotrexate is an anti-metabolite drug and will take considerable time to reach full effect. Up to 3 to 4 months may be required. 4. Concomitant use of oral 5-ASA or antibiotics with immunosuppressant therapy has not been shown to be of benefit in controlled trials. C. Anti-TNF therapy, 1 for patients refractory to or do not tolerate systemic steroids and immunosuppressant therapy. 2. In perianal fistulizing CD, Infliximab is effective therapy. Infliximab 5 milligrams per kg at 0, 2, and 6 weeks. A relapse at 1 year is high if infliximab stopped. B. ATI formation is common in non-continuous therapy and may decrease efficacy of future courses of therapy. ATI formation may be limited with concomitant dosing of azathioprine, 6-MP, or methotrexate. C. Concomitant therapy with 5-ASA, steroids, or antibiotics is of little added benefit. 4. Iomab 160 mg day 1 and 80 mg day 15, followed by 40 mg every other week starting on day 29. 5. Certolizumab pegol is given as a 400 mg injection on day 0 and weeks 2 and 4. Diseases of the bowel, inflammatory bowel disease, and irritable bowel syndrome 925. D. Other biologics. 1. Natalizumab has been shown successful in inducing remission of CD. Due to the risk of PML, its use is limited to cases failing all other therapies. 3. Severe or fulminant acute CD includes active disease of a severe nature, toxic enteritis or colitis, megacolon, small bowel obstruction, and abdominal abscess. The patients often require hospitalization secondary to severity of disease and risk of complications. The typical therapy may include 1 IV fluids and bowel rest parenteral nutrition. There are 2 IV antibiotics with metronidazole, aminoglycosides, and broad-spectrum penicillin or third-generation cephalosporins empirically for possible abscess or infections. And 3. IV corticosteroids. B. Anti-TNF therapy with infliximab may be useful for patients who do not respond to IV corticosteroids. C. Natalizumab may be useful for patients not responding to anti-TNF therapy. D. Surgical intervention may be required in patients who do not respond to IV corticosteroids and infliximab. 4. Maintenance of CD remission strategies have been of questionable efficacy. Historically, long-term treatment with 5-ASA agents and broad-spectrum antibiotics has been advocated with a lack of convincing controlled clinical data to support these measures. Newer evidence-based approaches may change therapy strategies. Immunosuppressants, 1-azathioprine, 6-MP, or methotrexate have been used in maintenance, but adverse events must be weighed carefully, especially in patients with mild disease. 2. Azathioprine, 6-MP, and methotrexate may be useful in patients unable to wean off systemic steroids. B. Biologics. Anti-TNF therapy is effective at inducing and maintaining clinical remission in Crohn's disease. 1. Infliximab 5 mg per kg infused every 8 weeks. 2. Adalimumab 40 mg injection every 2 weeks. 3. Certolizumab pegol 400 mg injection monthly. 4. Concomitant. Azathioprine, 6-MP, or methotrexate can also reduce ATI formation with infliximab injections and may increase efficacy. Skillful monitoring is essential to successful use of these agents. All anti-TNF antibodies have black box warnings regarding infection and malignancies. 6. Efficacy of natalizumab for maintenance of CD remission appears to be similar to anti-TNF antibodies. However, due to risk of PML, its use is limited to those who have failed treatment with the former. C. Systemic steroids are normally avoided in long-term therapy secondary to systemic toxicity and lack of convincing data to support their use. D. Antibiotics have not been shown in controlled clinical trials to be effective in maintaining medically induced remission. D. IBS 1. The treatment of IBS is based on the nature and severity of symptoms, correlation of symptoms to food intake and/or defecation, degree of functional impairment, and the presence of psychosocial or psychiatric disorders. Treatment is highly personalized, symptom-based, and can be generalized as follows. 2. Mild IBS is the most common disease presentation and is normally associated with few psychosocial problems. A. Education about disease and support can be of great benefit. B. Diet and lifestyle changes. 1. Specific foods are usually not as important as the size of meals, with smaller meals being preferable. Care should be used and restrictive diets should be avoided. Decrease fatty foods. Gas-producing foods. 3. Decrease alcohol. 4. Decrease caffeine. 5. Avoid dairy and lactose intolerant patients. 926 Chapter 45 2. D. 6. Excess fiber can also increase IBS symptoms. 7. Prepare strategies to handle stress. 3. Moderate IBS symptoms. which are normally intermittent but can be disabling at times. These patients suffer from more symptom-related distress. Patient symptoms historically are also associated with more gut reactivity, worse with eating, and better with defecation. Consider management strategies described earlier with drug therapy targeted predominant symptoms. A. Pain. Consider use of anticholinergics or antispasmodics. These agents have shown benefit in relief of IBS-related abdominal pain. Caution of anticholinergic adverse effects, dry mouth, dizziness, visual changes, etc. is advised with their use. 1. Dicyclamine denol 10 to 20 mg PO2 4 times daily. 2. Iocyanine. Anaspaz. Levsin 0.125 to 0.205 mg POQ. Max 1.5 mg day. 3. Clydinium chlordiazepoxide 2.55 mg Librax 1 to 2 tabs PO amp H. Or hyoscyamine scopolamine atropine. Phenobarbital, Donatal 1 to 2 tabs Q6 to 8 HRS. 5. Low-dose tricyclic antidepressants. Low-TCF for pain control. The dosages typically used are below effective doses used for clinical depression. TCA also may slow GI transit time and be useful in diarrhea-predominant patient cases. Amitriptyline, initially 10 mg at bedtime. D. Desipramine, initially 10 mg at bedtime. B. Diarrhea. Consider use of conventional antidiarrheals prior to trial of other agents. 1. Diphenoxylate atropine. Lomotil 0.025 to 5 mg 2 tabs per QID. Maximum of 8 tabs per day. Loperamide Imodium. 4 mg followed by 2 ng after each unformed bowel movement up to a maximum of 16 mg a day. 3. Elocitron. Lotrenex is a 5-HT3 antagonist and is available in the United States through a manufacturer-sponsored access program and is only to be used for diarrhea-predominant IBS in women. A. Access to prescribe is restricted in the United States to a manufacturer-administered program. B. Severe IBS dose in women only is 0.5 to 1 mg POB. Or rifaximin. This is an unabsorbable antibiotic indicated for traveler's diarrhea and hepatic encephalopathy. Rifaximin has been shown in phase 3 trials to be more effective than placebo in relieving symptoms in non-IBS patients. A. Rifaximin 550 mg TID. For 2 weeks. C. Constipation, 1 fiber, and bulking agents. This class is often recommended as the first line for treating IBS-C. Various agents have shown some minimal benefit. Fiber supplementation can worsen bloating symptoms, so low starting doses with upward titration are recommended. A. Psyllium 25 to 30 gm daily in divided doses. Methylcellulose 0.5 to 3 gm daily in divided doses. Methium polycarbophil 1.25 to 5 gm. Daily in divided doses. 2. Laxatives. Laxatives are an alternative first-line therapy for IBS-C. Their efficacy is less well-studied than bulking agents. Concerns with their use include worsening bloating or cramps and electrolyte loss. Osmotic laxatives are favored over stimulant laxatives. Polyethylene glycol, PEG, Miralax, and others, is an osmotic laxative solution that increases the amount of water in the intestinal tract to stimulate bowel movements. Potassium, sodium, and other minerals are also included to replace electrolytes that are passed from the body in the stool. Polyethylene glycol is available by prescription or OTC, and is generally considered to be very safe for constipation, and may be of benefit to IBS-C patients. Caution should be used in severely constipated patients or patients who may have an obstruction. B. Senna alkaloids or bisacodyl may be tried to relieve constipation where PEG was unsuccessful. Chloride channel activators. Activation causes for movement of chloride, sodium, and water into the lumen of the intestine. I. Lubiprostone amitiza is a chloride channel activator indicated for idiopathic constipation. It is approved for use in women with IBS-C at a dose of 8 mcg twice daily. Diseases of the bowel, inflammatory bowel disease, and irritable bowel syndrome 927. 4. Severe IBS is a very small proportion of the entire IBS population. GI complaints can be refractory and of continuous nature. Psychosocial and psychiatric comorbidities are common. A. Antidepressants, including the selective serotonin reuptake inhibitors, are often useful in severe IBS patients due to the increase in psychosocial components to patient presentation. B. Anxiolytic drugs, including diazepam, are occasionally used for IBS when patients are experiencing acute anxiety that is worsening their symptoms. In light of the risk of dependency, these drugs should only be taken for short periods. C. 5-HT4 receptor agonist tegaserod. Zilnorm is a 5-HT4 agonist for constipation-predominant IBS in women and is only available in the United States for emergency situations via petition of the FDA. Use of this drug is so restricted due to its cardiovascular risk profile. 1. IBS-C dosing women only is 6 mg per b.i.d. before meals. Third, complications. A. IBD. 1. UC and CD have many similar presenting features as well as commonalities and complications. The majority of UC patients will have a chronic relapsing disease course. Length of disease is related to risk of colectomy and colorectal cancer. Mortality is similar to rates in non-UC populations. CD may impose a slight increase in mortality with long-standing disease. 2. Musculoskeletal manifestations of IBD are the most common extraintestinal manifestations of the disease. Arthralgias in the absence of arthritis signs are the most common complaint. 5% to 20% of IBD patients experience peripheral arthritis pain that is self-limiting and coincides with IBD disease flares and resolves with successful treatment of B. Occurrence is nearly equal between males and females. Ankylosing spondylitis in IBD is less common at approximately 5% and is equal in UC and CD. Males are affected more than females and course is usually not related to the course of IBD. 3. CD fistulas and abscess. Long-standing inflammation may progress into penetrating disease, abscess formation, and fistula formation. These penetrating communications can be from diseased organ to neighboring organ, peritoneum, and to the skin. Fistula types include perianal fistula, enteroenteric, enterocutaneous, enterovesical, and rectovaginal. 4. Hemorrhage in the colon is relatively rare in UC but is serious. Acute hemorrhage accounts for a significant percentage of urgent colectomies in UC. Severe bleeding tends to occur early in the course of disease. Hemorrhage in CD is extremely rare. 5. Strictures or narrowing off the colon or rectum occurs in a small percentage of the UC population. Importantly, nearly 1/3 of strictures may be related to malignancy, and as such strictures should be carefully evaluated. 6. Toxic megacolon is a serious complication mainly seen in UC but occasionally in CD as well. It occurs when the inflammatory process causes the colon to dilate with subsequent bowel wall thinning. This results in the bowel becoming more fragile. The major risk is bowel perforation. Bowel dilation that does not respond to therapy within 72 HRS is considered an indication for surgical resection. 7. Cancer. Overall, UC patients are at higher risk of developing colorectal cancer compared to patients without IBD. The risk to individuals is variable and is related to duration and extent of UC as well as patient-specific history risk factors. Risk is greatest in patients with pancreatitis of long-standing duration. Colorectal cancer is also a risk in CD patients, especially if it is CD involving the colon. Risk of cancer of the small intestine has been noted in CD also. 8. Primary sclerosing cholangitis. CRIPC is the most common hepatobiliary complication of IBD. PSC affects men more than women. PSC is more common in UC than CD. 9. Osteoporosis as evidenced by increased fractures and diminished bone density has been shown in CD patients. 10. Quality of life impact. While most IBD patients are able to lead nearly normal lives, many do suffer significantly during active flares of disease. The chronic nature of disease also has a negative impact on patient col. B. IBS. Although IBS has been shown to produce substantial physical discomfort and emotional distress, most patients with IBS do not develop serious or long-term health complications. Most patients also learn to control their individual symptoms with diet and lifestyle modification or medical therapy as needed. 928, Chapter 45. For questions 1, presents a 35-year-old male presents to his physician with a primary complaint of abdominal pain and frequent bowel movements over the past few weeks. Upon examination and routine laboratory testing, he is found to have a low-grade fever and an elevated erythrocyte sedimentation rate. Further questioning reveals he is having 4 to 5 loose bowel movements each day. The patient is a past smoker. Stool antigen tests are negative for known GI pathogens. Physical examination and colonoscopy reveal contiguous inflammation of the rectum and most of the descending colon. The physician diagnosis is mild to moderate ulcerative colitis. 1. Which therapy would be the most effective for inducing remission? A. Topical corticosteroids. B. Topical 5-ASA. C. Oral budesonide. Topical 5-ASA plus oral 5-ASA. 2. Once remission is achieved, which therapy is most appropriate for maintenance? Sulfasalazine 2 grams day. Bolsalazine 2 grams day. C. Osalazine 4 grams day. Topical corticosteroids. For questions 3, 4. An 18-year-old female with newly diagnosed mild Crohn's disease within the ileum returns to her physician for her first follow-up since starting treatment. 3 weeks ago, she started oral sulfasalazine 4 grams a day and azathioprine 25 milligrams a day. Since starting these meds, her symptoms have not improved. If anything, they are slightly worse. She is ambulatory with no signs of toxicity, blood per rectum, pain, anemia, etc., or weight loss. 3. What would be a logical next step in therapy? A. Stop azathioprine and begin IV corticosteroids. B. Stop sulfasalazine and begin oral budesonide 9 milligrams a day. C. Stop azathioprine and begin prednisone 40 milligrams orally per day. D. Stop sulfasalazine and begin Lialda 4.8 gm day. 4. Remission of her first episode was successful. Unfortunately, full-dose azathioprine alone has been unable to maintain effective control of her CD. Over the past 18 months, she has had numerous flare-ups. They resolve with each burst of acute therapy, but return with azathioprine alone. Her symptoms are increasing moderate disease, and her schooling is beginning to suffer. What would be a logical next step in therapy? A. Change azathioprine to 6-MP at 1.5 milligrams kg day. B. Add metronidazole 750 milligrams day. C. Surgical resection with ostomy. D. Add infliximab 5 milligrams kg every 8 weeks. For question 5. A man with diarrhea-predominant IBS is experiencing interruption of his work as a truck driver secondary to frequent bouts of diarrhea. He states his symptoms are worse after eating, especially fried foods. His physician discusses the possible benefit of avoiding fat in his diet. The patient agrees to try but also asks for something to use in emergencies. Up to 16 milligrams a day. D. Fluoxetine 40 milligrams q. 6. Which of the following is the most appropriate initial therapy for a woman with severe constipation-predominant IBS? A. A restrictive bland diet. Tegaserad 6 milligrams POB. Allocertron 1 milligram POB. Study questions. Diseases of the bowel. Inflammatory bowel disease and irritable bowel syndrome 929. 7. Ulcerative colitis and Crohn's disease present in very similar ways. There are several clinical differences between the diseases that can help differentiate them. Which of the following clinical features is more common in Crohn's disease than in ulcerative colitis? A. Abnormal bowel movements. B. Slow onset of disease. C. Joint pain. D. Fistula formation. 8. Patient-prescribed anti-TNF agents such as adalimumab should be monitored carefully for which of the following adverse events, according to black box warnings included in prescribing information? A. Increased risk of severe loss of bone density. B. Increased risk of critically high potassium levels. C. Increased risk of toxic megacolon. D. Increased risk of pneumonia. 1. The answer is D. C2B2. Topical 5-ASA therapy plus oral 5-ASA therapy has been shown to be superior to either alone or topical steroids at inducing remission in mild to moderate UC. Budesonide allele release will not likely reach the site of disease in this patient as he has left-sided disease.